notice a question in the chat, please feel free to let me know, but I'll certainly try to pay attention to that and certainly come back to them too at the end. So we're going to be talking about opioid use disorder and pain. And again, these slides were put together by Dr. Bott. So the objectives are to describe and understand the clinical importance and utility of the comorbidity of opioid use disorders and pain, to understand how medications for opioid use disorders don't preclude the need for effective pain management, and to describe and apply strategies to manage pain in patients who are on opioid replacement therapies or treatment for opioid use disorder. So we'll talk a little bit about the prevalence. The percentage of patients who have opioid use disorder and co-occurring chronic pain, you can see that there's a range here from various studies over the past couple of decades, from 37% to upwards of 64%. So there's really quite high prevalence. The relationship is bidirectional, but usually pain does come first. And when there is the co-occurrence, and then we see development of opioid use disorder, but it can go the other way. In a large sample N of over 5,000 adults with opioid use disorder, they found that the majority, so 40% had pain first and then opioid use disorder. 35% had no pain. About 10% had opioid use disorder first and then developed pain. And this is an interesting thing too, where sometimes people can get more pain due to high doses of opioids, or otherwise known as hyperalgesia. And then 15% had both occurring at presentation, so both opioid use disorder and pain. We see that patients who had chronic pain before the onset of opioid use disorder also had higher rates of mental health conditions and other health conditions. And patients who had opioid use disorder before the onset of pain were more likely to have co-occurring substance use disorders, such as stimulant use, alcohol use, and co-occurring HIV and hepatitis C that have higher prevalence in patients who have a history of injection use. So we'll talk about acute pain management first, and then we'll move on to chronic pain management. This, I remember Dr. Bott saying, is a picture that he got from online that was open to the public. And this is drawn by a patient. I can see here, she's naming it overwhelmed. This is the feeling of this acute pain, which is very overwhelming, sort of the angry picture. So we'll have a vignette to move forward with. So AN is a 45-year-old female whose status post-shoulder surgery. She has a history of opioid use disorder and had been treated twice in the past with methadone. She stopped treatment and both times did experience relapse, which is quite common when patients stop. She was using 0.5 gram, 2 to 3 times a day of heroin, which she was smoking prior to her surgery. Then during surgery, she was on morphine, continuous infusion, plus breakthrough doses. And last 2 hours ago was the last dose. And she's requesting more pain medication. She's reporting the pain as 9 out of 10. She's in tears and clearly in great discomfort. Her vital signs are stable. And one of the nurses came to let the provider know, in quotes, saying she is drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen her addiction. So what are some commonly held beliefs? So acute pain is frequently undertreated, and this is up to 60% undertreated in the inpatient settings. And we see this even more so in patients who have substance use disorders. We know that addiction is seen by healthcare professionals as primarily a social problem that requires law enforcement rather than a health problem that requires prevention and treatment. And we also know that when patient, this has come up and I think talks about stigma as well, that when patients have that sort of blame assigned to them that they have poor health outcomes. But unfortunately, this is a commonly held belief still in healthcare. There's sort of this perceived controllability, that the providers feeling like they're being sort of manipulated, and hence then blaming the patient for what is truly their pain that they're clearly experiencing, but isn't being understood as real. So what is a suggested approach? To accept the person's self-reported pain, really giving them the benefit of the doubt. We know that pain behaviors will vary widely, and that some patients may have very little pain after a surgery, and some may have exquisite pain. And certainly, again, that in the setting of substance use disorder, that may be more intense. We also know that vital signs are not very reliable as an indicator of pain intensity. You want to also consider that the addiction versus pseudo-addiction versus physiological dependence, so that there may be three different phenomenons going on. And so if required, you don't want to withhold opioid analgesics from people who have substance use disorder and are suffering acute pain. There's no data that shows that acute pain management will worsen addiction. I know that this is a commonly held belief that, we're concerned to dose them because we might worsen things for them. But really untreated pain will contribute to cravings and actually increase one's risk of a relapse. And two studies on patients who were on medication for opioid use disorder showed that opioid analgesia for acute pain did not increase their chances of relapse. So the suggested approach is, again, to understand that because they have a higher level of tolerance, so they may be on methadone at baseline, for instance, but that's not treating the acute pain, and they have a higher tolerance to opioids. And so just to remember that they may actually require higher doses of opioids in the setting of acute pain than someone who's not already opioid tolerant, but you do need to monitor them closely. The risk of respiratory suppression may be lower in patients who are opioid tolerant. Still important to monitor them though. And remember that opioid agonist treatment is treating their baseline substance use disorder, but not their acute pain. Yes, I think I see the question. Thank you from Dr. Harrington about the vital sign thought to be, yeah, thank you, Dr. Hager, if you can chime in there, I appreciate that. So we'll talk about the ED acute pain management, and you can follow this column on the left as a guide. This is for patients who are on buprenorphine for opioid use disorder, and they're coming in to an emergency setting for acute pain management. You always, first want to consider any non-opioid analgesia that may be helpful depending on what their need is. And so that can include ice, immobilization, relaxation techniques, elevation, compression, etc. And then if not contraindicated, acetaminophen and NSAIDs certainly can be good options still. At the top of the column though, where you see continue the maintenance buprenorphine, this is very important. So we're not going to be stopping it, which was still is, I think, a commonly held belief to stop it if we're going to be treating with additional opioids, but we're going to continue it, but also consider dividing the dose for pain management, because we know that once a day dosing is very effective for opioid use disorder, but for pain, the effects are improved for buprenorphine if it's dosed more frequently. And so if someone's taking their buprenorphine as a once or say twice a day dose, you may consider dividing that dose to every 4 to 6 hours. You may also consider that they may need a slight increase in their dose, but I think that comes up in a later slide, so I'll wait on that. And then think of some alternatives to opioids, such as the following. So here we saw some of those initial ones with comfort measures. You may also consider trigger point injections. Sorry, I'm going to turn off my tiger so it's not loud. Okay, sorry. I had to do that before I started. Lidocaine maybe in acute settings may be needed IV. Lidocaine patches may be effective. gabapentinoids, regional nerve blocks, but here, for instance, in the setting of rib fractures, hematoma blocks, and then the patient may require additional opioids. Now, fentanyl is known to override the buprenorphine at the mu receptor. So in a situation of emergent pain with someone who is on buprenorphine, fentanyl, even though buprenorphine has very high affinity to those receptors, fentanyl can push it off and have an effect to help treat pain. And hydromorphone may also help in addition to the buprenorphine to treat the pain. And then the other option 2, is to increase the sublingual buprenorphine dose. So that's what I was thinking was coming on another slide, but here we go. So I think rule of thumb is you can consider a 25% increase for pain. So for instance, if someone's on a dose of 16 milligrams a day, you can consider increasing their total dose to 20 milligrams and having that be split in a dose every 4 to 6 hours. And then in some situations, starting IV buprenorphine, of course, in the ER setting may be helpful. And then here, I'm not going to go into detail in reading all of this, but you can look down the column and just kind of see the other options that may be helpful. Certainly some more advanced regional nerve blocks, if that's something that is available. Subdissociative ketamine and IV push doses. It may be used in the emergency setting as well. I think Dr. Warwick may be joining us later for the Q&A and would certainly have answers to questions about that. And also considering your alpha-2 adrenoceptor agonists such as clonidine. It's very important to master the non-opioid techniques of pain management in all patients, but particularly in patients who are on medication for opioid use disorder. Again, patients on these medicines have a high opioid tolerance, and naltrexone has a very high mu receptor binding affinity. So pain may be difficult to treat with most opioids in that situation. Another, as a side note, important reason to have your patients who are on naltrexone, whether it's PO, but certainly if they're on the long-acting monthly injection, whether for opioid or more likely so for alcohol use disorder, to carry a card saying that they're on it in the case of an emergency. And remembering that buprenorphine has that high binding affinity, and so it requires really strategizing the addition of other opioids to help cover pain in these situations. Remember too that methadone is a long half-life full mu agonist, so it has a lot of variability too in terms of its half-life, so you need to be cautious with its use for pain, but certainly in terms of being, doesn't have as high an affinity as some of these other opioid agonists such as fentanyl. We'll talk a little bit about methadone and acute pain management. Thank you. So again, if someone's presenting in an acute setting and they're on methadone, you want to continue their baseline methadone after verifying their dose from their clinic. If the dose can't be verified, say it's for the timing that they present at, until you can verify it, it's safer to break up the self-reported dose into 3 times a day to 4 times a day dosing rather than giving it all at once, again, with that variable half-life. Just to be cautious with that. Plus adding in the short-acting opioids for breakthrough pain. Gradual, if there's going to be an increase in the methadone dose, it needs to be done very gradually. And you do not, of course, administer buprenorphine because that can cause precipitated withdrawal. Since methadone is a full agonist that their receptors are used to, it will precipitate withdrawal. If patients are unable to take their oral dose, they should be given IV methadone, and the IV dose would be reduced by 1/2 to 2/3 and can be given in those divided doses every 6 to 8 hours. And then methadone for analgesia is given multiple times a day. It can be prescribed by any clinician with a Schedule II license. Don't recommend it, certainly not certainly not first-line treatment and would need to be done very cautiously and in conjunction with, I think, conversation with a pain specialist, just to be done safely if it's required. Methadone for opioid use disorder is once a day dosing, and this is only done through an opioid treatment program, so a regulated methadone dispensary. Sometimes we do split the dose, but that's usually just in case of patients who have very high metabolism established of their methadone or latent pregnancy. So what about buprenorphine and acute pain management? Again, we want to employ all those non-opioid modalities that we discussed. And then we can first adjust the buprenorphine dosing interval. So again, if they're on a total dose of 12 milligrams daily, we could divide that into 4 milligrams 3 times a day, etc. You might also temporarily increase the dose of buprenorphine. So I know I'd mentioned 25%. Here the example is from 8 milligrams twice a day to 8 milligrams 3 times a day. And then consider in the emergency setting IV buprenorphine. You want to augment with short-acting opioids that have that high mu receptor binding affinity. So again, namely fentanyl, and Dilaudid also has that higher binding affinity, but is longer acting, so less able to titrate easily. And then certainly you can consider calling to discuss a case with a addiction medicine specialist. So now just shifting gears slightly to perioperative management. It's just important to remember that in general, patients who have a history of substance use disorder do carry a lot of history of internalized and external stigma and experiences that didn't go so well in the medical field, for one, and so they may fear mistreatment, and providers may fear deception. And so encouraging as much as possible our patients to be forthcoming in talking with their providers it is helpful, but also inviting them to allow us to discuss their care with the surgeon and anesthesia team is really, I think, best practice. There is a lack of consensus in the field about how to manage pain in patients who are on buprenorphine. It used to be really that even for minor surgeries, patients would be told to stop the buprenorphine and then just be on the short-acting pain medication and then restart it. But this really put people at a lot of risk for either relapsing when they had to, if they were on the short-acting agonist for a long time and then had to transition back, they have to go through withdrawal to restart the buprenorphine, or just being lost to care. So but really that shifted to continuing the buprenorphine. So in the pre-op stage, it's important to confirm multi-party consent and the coordination of care with providers. So again, that important communication. And then in general, not discontinuing the buprenorphine. There's some thought that we should lower the dose to 8 to 16 milligrams in divided doses during the perioperative period, so as to kind of open up some availability of those mu receptors if the patients were on higher doses. And I think he brings up this article by Anna Lemke, which is a nice summary of that in a bit, I think I saw. So again, the current evidence does not support the practice of routinely discontinuing buprenorphine before surgery. Remembering that buprenorphine itself is a powerful analgesic, and it can be combined synergistically with other opioids. So you keep the buprenorphine on and maintain it through surgery. Yeah, so this is a nice, this is the article I was mentioning by Lemke et al. And out of Stanford about patients maintaining a buprenorphine for opioid use disorder should continue it through the perioperative period. And in this article, there's a nice flow, I don't think it's here, but there's like a nice flow diagram that sort of shows a step-by-step approach. And I think this is mainly looking at, so for patients who are on 16 milligrams or more, kind of the what they suggested in terms of decreasing it slightly, I think to 12 milligrams throughout the perioperative period and then increasing it back up. But there are different practices, but certainly in the overriding consensus here is maintaining them on the buprenorphine. So we'll talk about naltrexone in acute pain management. We touched upon this briefly before, that patients should be advised to always carry a card that informs medical personnel when they're taking the injectable naltrexone in case that they weren't able to let them know in the moment that they needed treatment. And it's suggested to try regional analgesia if possible, or the use of non-opioid analgesics. But if they do require opioid analgesia, just to remember that the amount of the opioid required may be greater than usual, and the resulting respiratory depression may be deeper and more prolonged. Yes, Dr. Harrington, I think we can get a copy of that article. I know I actually have it here somewhere, and so afterwards, if Julie reminds me, I can try to send that. Thank you. So because of this risk, patients should be continuously monitored in an anesthesia care setting by people not involved in the surgery itself or the diagnostic procedure itself. And the opioid therapy should be provided by individuals who are specifically trained in the use of the anesthetic medication and the management of respiratory effects of the potent opioids, making sure that they'd be able to attend to their airway and ventilation. And a rapidly acting opioid analgesic that minimizes the duration of that respiratory depression is preferred, and again should continue to be monitored in a setting that's equipped to help if needed. So again, just kind of summarizing and comparing these two for patients who are on methadone and buprenorphine. For methadone, again, we want to confirm the dose, continue the regular dose. If you're not able to confirm that dose, then you may need to divide it. If you're starting methadone, and certainly if you're not able to confirm it, you wouldn't give more than 20 to 40 milligrams on day one, at least not unless you were then dividing the dose if they were on reporting a larger dose so that you could monitor it. For starting methadone for the treatment of opioid use disorder, though, this is the limit, would be no more than 40 milligrams on day one. And then you want to provide additional short-acting opioids, and then at discharge, provide the exact time of the last dose. For buprenorphine, again, here are the two methods, and the first one is not recommended anymore to stop the buprenorphine. We would like to continue the buprenorphine and use additional buprenorphine if needed, or full agonists, maximize our non-opioid treatment, and possibly divide the buprenorphine dose if not already taken in divided doses. This table, I think, is just kind of summarizing that again. So I'm not going to read through it, but I'll let you kind of take that in there as far as the considerations for the perioperative period for patients who are on buprenorphine, methadone, and naltrexone. Now, this table is looking at intraoperative non-opioid pharmacologic agents for analgesia. Again, I'm not going to read through this, but you can kind of glance through the different options. Here we have listed from ketamine down through clonidine, lidocaine, and then your non-steroidal anti-inflammatory medications. And these are all given in IV doses in this presentation table. And again, this is also just kind of summarizing some of these medications for pain management with a multimodal approach. So again, your opioid options, regional anesthesia, etc. So now let's shift gears in the last, I think we'll just take another 5 to 10 minutes and then have hopefully some time for questions. Chronic pain management. This is another image, I think, drawn by a patient that Dr. Bott either knew or found online, sort of describing the experience of chronic pain. So some basic considerations. Remember that a history of opioid use disorder is the single biggest predictor of aberrant behaviors to prescribed opioids. So you want to be really cautious in the prescription of opioid, and would not be a first line approach, certainly for anybody, but I want to be really cautious if your patient does have that history. Consider consulting a pain management specialist, and we do know that use of a multidisciplinary team can be most effective. Remembering that using non-opioid and adjuvant medications should always come first. So again, NSAIDs can be helpful if not contraindicated. SNRIs, so duloxetine, venlafaxine can be very helpful. Tricyclics, if not contraindicated, and need to be monitored a little bit more, but can be very helpful. Your membrane stabilizing agents, gabapentin, and then your non-pharmacologic therapies. So CBT for pain has a good body of evidence, acceptance and commitment therapy, yoga, meditation, traditional healing, and then the interventions such as nerve blocks, TENS unit, trigger point injections, things like that can be very helpful. Responsible opioid prescribing, again, this goes back to the CDC guidelines that I think everyone knows well, but we need to be aware of individual risk factors, use our screening tools, monitor for any concerning behavior that may put one more at risk if they are taking a opioid medication for pain, and then using just the regular methods of ensuring safety, including urine drug screens, monitoring the PNP treatment agreements, and certainly co-prescribing of naloxone, making sure that everyone has a current prescription present. So one other vignette here for chronic pain in a patient on buprenorphine. So this is a 55-year-old female who's presenting for treatment of her substance use disorder. She has a 12-year history of chronic pain that followed an ATV accident and a pelvic fracture. She's been gradually increasing the doses of her opioids up to 300 morphine milliequivalents per day. She's been buying some off the street, going to different doctors, experiencing problems in marriage, at work, experiencing worse depression and anxiety, and states her pain is just all over and worse than ever. And in this situation, the patient started on buprenorphine 4 milligrams 3 times a day and experienced an improvement in her pain, felt happier and felt that she had her life back. And I think this is also an example of that hyperalgesia effect. Most likely she was getting increased pain from that extremely high doses of opioids, and buprenorphine having pain benefit as well, but certainly could also address that. So if chronic opioid analgesics are required for pain control, buprenorphine may make it difficult to get the full effect from the full mu agonists, but it's the working at the receptors in the fluid sort of nature, and so certainly some additional opioids, as we discussed, can be helpful. But buprenorphine maintenance may need to be discontinued. A subset of patients with chronic pain and a history of opioid use disorder may experience reduction of pain with buprenorphine naloxone maintenance when divided in daily dosing needed for analgesic control. Importantly, if they do have co-occurring opioid use disorder and pain, and you're prescribing with your X license for buprenorphine, the primary indication is always the opioid use disorder. Secondary would be for pain. And again, that may help mitigate what I just mentioned on the other slide, the occurrence of opioid-induced hyperalgesia. And why might buprenorphine be a good option as frontline analgesic? Here are many options, many reasons. I'm not going to read through them all, but there may be more effective pain management, certainly for particular types of pain. There may be less constipation, which can be really aggravating, although patients who are on buprenorphine often do experience it, so it's still important to proactively address that. There's that ceiling effect on respiratory depression, less cognitive impairment, and it's relatively safe in the elderly and for patients who experience renal failure. Importantly, too, the withdrawal, it's so long acting, and the withdrawal tends to be milder, although we do not recommend that patients stop it abruptly. And then just to kind of show here the conversion of high dose opioids to buprenorphine for chronic pain, you can see here in blue was the pain before, and in red was the pain after for their pain score. And this is the morphine equivalent ranging from 200 all the way up to over 1,000. And you can see that in all these instances, once patients transitioned to buprenorphine for their chronic pain, they had a significantly decreased level of pain. Again, sublingual forms of buprenorphine are not approved for treatment of chronic pain, but they can be effective and commonly used. It's just, again, the primary indication would be opioid use disorder. However, buprenorphine patch is approved for treatment of chronic pain, and that can be prescribed for that indication alone without the X. This is the suggested dosing for patients who are opioid naive, starting the buprenorphine patch dose. And then he gives here for patients who are on less than 30 morphine equivalents, again, the 5 microgram patch, and then increasing it if they're on higher than that to the 10 microgram patch. And then certainly you can augment it if needed with other opioid and non-opioid analgesics. So I'll try to go quickly here. I guess we have another vignette. 64-year-old female presents to the ED with dysuria, was found to have advanced cervical carcinoma with local metastasis, and need for pain management was identified. There was concern raised about her 30-year history of heroin addiction and concerns about IV use. Patient was started on methadone and carefully titrated up at an OTP, and she was placed on short-acting opioids for breakthrough pain, all done in close collaboration between the OTP physicians and oncologists. So again, another instance of how important it is to, with consent, work with colleagues for best management. And in some cases, patients' opioid dependence may be treated better with methadone maintenance to potentially avoid the complications of possible withdrawal if the buprenorphine is initiated too soon, or difficulty obtaining effective analgesia. For naltrexone in chronic pain, patients with chronic pain who may require opioid analgesia aren't good candidates for treatment with naltrexone, so you'd want to consider again using buprenorphine or methadone. And that brings us to the end of this talk. I'm going to stop the